Hi and welcome back to another video of Medic Notes. This video is on apnea. Apnea is defined as the cessation of airflow, due to either lack of respiratory effort, central apnea, or upper airway obstruction, obstructive apnea. Central apnea is more common in infants, and obstructive apnea, especially during sleep, is more common in older children. Central apnea lasting less than 10 seconds is common in healthy infants, and can be present in normal children during sleep, especially after a sigh breath. Central pauses lasting longer than 15 to 20 seconds are considered abnormal. Premature infants can have apnea of prematurity, which consists of recurrent apneic episodes that are often of central origin, although they can be mixed central or obstructive. Apnea of prematurity should resolve by 44 weeks post-conceptional age. Central apnea outside of infancy is a rare occurrence and warrants evaluation. This is a table showing the categories of apnea. Apnea of prematurity occurs in premature babies less than 36 weeks gestation, due to central control and upper airway obstruction. Usually treated with caffeine, HFNC, CPAP, or intubation. Later I will talk about other categories, including central apnea or hypoventilation, obstructive sleep apnea, and breath-holding spells. For congenital central hypoventilation syndrome, it is a rare genetic disorder, in which there is profound loss of respiratory control during sleep, leading to primary central apnea, hypercarbia, and hypoxemia. Most patients with CCHS have a defect in the PHOX2B gene, which is necessary for autonomic nervous system development. Infants with CCHS typically have respiratory difficulties within the first several weeks of life, although it can also present later in childhood. CCHS is associated with an increased risk of Hirschsprung disease and neural crest tumors. Other genetic syndromes associated with abnormal central respiratory control include Rett, Joubert, and Prader-Willi syndromes, and tuberous sclerosis. Secondary causes of central apnea and hypoventilation are more common and include medications impairing central respiratory drive, such as narcotics. Increased intracranial pressure, central nervous system tumors, myelomeningocele, Arnold-Chiari malformation, and mitochondrial or metabolic disorders. Another category of apnea is breath-holding spells. This is a form of apnea occurring when a young child is awake, usually triggered by emotional stress. They often follow a sustained exhalation, so can be associated with cyanosis, and loss of consciousness that is quite alarming. The return of spontaneous breathing usually occurs quickly. Most breath-holding spells are benign and lessen over time, but seizures and disorders of central respiratory control should be considered. The other category is obstructive sleep apnea syndrome. This affects 2 to 3% of young children, with peak prevalence at 2 to 8 years of age. It is caused by complete or partial upper airway obstruction during sleep. Control of breathing is usually preserved, although infants and others with immature respiratory control may have obstructive and central apnea together. Restless sleep, behavioral problems, and inattention or hyperactivity are more common in young children than the classic adult findings of daytime hypersomnolence and loud snoring. Some children experience poor somatic growth due to interruption of normal growth hormone production during deep sleep. A small subset can have significant hypoxemia and hypercarbia, leading to morning headaches, and if untreated, pulmonary hypertension and cor pulmonale. Not all children who snore have OSA, and not all children who have OSA snore. Thus, when the diagnosis is in question, it should be confirmed with a polysomnogram. PSG is the only definitive test for evaluation of obstructive and central sleep apnea. It involves continuous recording of electroencephalogram and electrooculogram for sleep staging, oronasal airflow and pressure, audible snore, chest and abdominal wall excursion, leg and chin electromyogram, electrocardiogram, pulse oximetry, and capnography. The measured score from a PSG is the apnea-hypopnea index, or number of times in an hour of sleep, that the child has cessation or reduction of airflow of a significant magnitude to negatively affect oxygenation or sleep stage. An AHI less than 1 is the generally accepted norm for pediatric patients, although the decision to treat often hinges on the severity of daytime impairment. Measured AI is typically worse in rapid eye movement sleep and when the child is supine, so an ideal study captures all sleep stages and positions. Adenotonsillar hypertrophy is the most common cause of OSA in young children, with peak age 2 to 5 years. Other risk factors for OSA include obesity, premature birth, craniofacial malformations, trisomy 21, and neuromuscular diseases. Treatment of OSA starts with determining whether the child will benefit from adenoidectomy, with or without tonsillectomy. If surgical intervention is not indicated or fails to alleviate the problem, then the use of CPAP, or BiPAP, via nasal interfaces can be used to distend the upper airway during sleep. This requires a tight-fitting nasal mask, which may not be well tolerated in young children. Supplemental oxygen can blunt hypoxemia in milder cases of OSA but does not alter obstruction and sleep fragmentation. In extreme cases, especially those associated with craniofacial abnormalities or hypotonia, tracheostomy may be indicated. That's all for this video. Thank you.